Thanks, Gordon, for inviting me. Thanks for that kind introduction. I got a cold. I hope everybody can hear me still. So I actually took the liberty of adding what's new here because I suspect most people in the audience know more or less how to treat intra-abdominal sepsis, kind of the basics. But we've talked a lot about what sepsis is. I'm not going to actually go through this now, except to highlight that what I'll talk about probably as the first speaker in the morning is the source control. So that's what I'm going to be talking. I'm not going to talk so much about antibiotics choices, indications, organ support, etc. Just before we get going, however, just one more slide about the definition. This came out last night. When I was reviewing these slides, I got an email alert from New England Journal saying that this paper just came out. And it highlights exactly what we've been talking about during the whole morning, namely that the current definition of sepsis is flawed. So this is from a very large database run, actually in my old hospital was included in this in New Zealand and Australia. This is Ronaldo Bellamos group, who publish a lot in ICU physiology and ICU care. And the main finding of this paper, which I haven't entirely digested yet because it's so new, but the main finding here is that in their 14-year database, they had 109,000 people with infection and organ dysfunction. And they looked at the issue of SIRS. And it turned out that while most patients indeed had a systemic inflammatory response syndrome, there were no less than 12% of patients who did not have any systemic inflammatory response syndrome, still had an infection and, secondary to this, an organ dysfunction. So this reflects very much what has been said during the morning about the definition most likely changing in the future. This is very good data to support that. So as surgeons, why do we worry about sepsis? Well, sepsis is, of course, a major cause of mortality in our patients as well, with patients with severe abdominal complications. This is data from 3 large intestinal failure units, not our own, but this is other units around the world, showing that overall mortality in patients referred to these units with severe intra-abdominal complications is about 10-13% perhaps, which is relatively accepted. I think it's lower nowadays actually, but back then this is what it was. And the sepsis was the main cause of death in most of these patients. So up to 96% of the deaths from severe abdominal complications is directly caused by sepsis. So it's very important for us. As we discussed, it's not a binary issue. There are other problems than death caused by sepsis. Sepsis completely prevents the patient from starting to recover after surgery or after abdominal disease. So this is a study from my old employer, University of Auckland, where we still have one of the 3 only neutron activation analysis machines in the world. This is a machine that can measure your the protein content of your body non-invasively, which is very difficult in critical illness. In this study, my former colleagues looked at patients with abdominal sepsis before and after 10 days of aggressive TPN, trying to improve these patients' nutritional status during sepsis. And the main finding here is that there was no gain of lean tissue mass in these patients. The only thing that was accomplished by very hypercaloric TPN was fat accumulation, illustrating that we need to treat sepsis before we can start the road to recovery. So what's new then in source control? So I'll focus on diagnosis, conservative treatment, and laparotomy for sepsis control. What is new here? And by new, I mean in the last 10 years or so. We start by looking at diagnosis. So cross-sectional imaging is, of course, still the gold standard to diagnose intra-abdominal sepsis. CT is, of course, mainly used. MR is probably a little bit more helpful in Crohn's disease than CT. And for obvious reasons, in young patients, we often use MR scans, especially if somebody will need a number of scans during a short period of time. The interesting thing here is the non-SIRS patients who have more insidious, chronic, perhaps long-term abdominal sepsis, or we suspect there is an infection in the abdomen causing organ dysfunction. This is patients who fail to recover, or fail to thrive, rather. They have low albumin levels that persist. They may be jaundiced. They may have other organ dysfunctions. But there's nothing to see on cross-sectional imaging. These patients can be studied further, and we and others have used white cell scans for quite a long time to look at these patients. I think the new thing that's coming now more and more is do PET CTs on these patients instead of white cell scans. The vascular surgeons have known about this for a long time. There's a whole literature around PET scanning in diagnosing vascular aortic grafts, especially infections. This is a comparison quite typical for this literature, where they compare, in this case, a kind of descending aorta to bifemoral graft of some sort, where the white cell scan was negative in this patient, but the PET CT nicely showed up an infection, highlighting that this is probably more sensitive than white cell scans. This is an Israeli study that's very interesting. This is 48 patients admitted to hospital for fever of unknown origin, and no conventional investigations, including CT and MRI in some cases, was negative. These patients all had PETs as a kind of a last resort investigation, and in 27 patients, the PET was positive. 22 of those were true positives, so a focal focus of inflammation in 10, infection in 9, and malignancy in 3 patients was diagnosed in this way. Importantly, 21 patients had a negative PET, and all of those were true negatives. They were not subsequently found to have any focal inflammatory disease anywhere or malignancy. Here's just another picture showing that the PET scan is perhaps a little bit difficult to read, but if you add the PET, you can nicely see a pelvic issue here in this patient. So there's a lot of papers on this, and I've used it on my patient, at least one patient in the intestinal failure unit, where we just couldn't find a source of sepsis, and they had a PET which nicely found a focus. What's new in conservative treatment of abdominal sepsis? Well, if we look at the guidelines, it's very clear that interventional radiology is the primary modality of treatment, of course. We're advised to image patients as quickly as possible, and then within 12 hours, ideally, we should control the source of sepsis. And we should do so by using the modality which causes the least physiological insult to the patient. This means we need 24/7 interventional radiology in modern surgery. And we could see from the NILA audit just shown by the previous speaker that 2/3 of hospitals do not have access to interventional radiology 24/7. In my hospital, that's even in our unit, where we have our intestinal failure unit, this is a problem. We have perhaps 20-6 interventional radiology. It depends who's on call. We don't always have interventional radiology. And I must say, this is coming from the outside of the UK, I must say this is one of the things that can improve surgical sepsis outcomes hugely. If we can improve availability of interventional radiology, I think that's one of the main problems we have with the surgical septic patients. So what are the current outcomes then from percutaneous drainage? This is some quite recent, relatively large audits and prospective studies. Successful drain placement is achieved in about 80 to 100% of these cases. Of course, hugely dependent on patient selection. In some cases, in my own experience, some of these cases can, if it's an abscess which is not amenable to drainage, we can reach them in other ways. I currently have a patient today on the way to Manchester Royal for a transgastric ultrasound-guided drainage of a very difficult deep abscess. So things can be done in this way in patients who can't have normal percutaneous drainage. Surgery was avoided in 78% of cases. That's quite a low number. So in my experience, I don't think 22% go to surgery. Morbidity from the drain is about 5%. Most of these are minor issues. Occasionally, we of course get major morbidity with IR. I think something that's highlighted by the IR literature, and they probably believe we do this, is to flush the drains daily. They want us to flush these drains all the time. I must say, in my experience, that doesn't always happen. I think that's a kind of a quality improvement, very simple to do, but which is very important, often missed on the wards. 21% of patients who have a drain require a second drain to the same collection after withdrawing the drain. This is European data. And I think the situation, that sounds pretty high, I think the situation is quite different in the States. From my years in the States, I can tell there's a completely different procedure when it comes to removing the drains. In Europe, or in the UK, including the UK, we tend to remove the drains when the output ceases. And often we re-image the patient to make sure the cavity has disappeared. In the US, I was a fellow there, we were not allowed to withdraw these drains without a sinogram. So we had to do a sinogram to make sure the cavity did no longer expand with gentle infusion of contrast. So they wanted these cavities to be essentially healed and scarred down before we were allowed to pull the drains out. And I think that's an important point, which is slightly difficult to enforce sometimes here. The second benefit of doing a sinogram, of course, where you can diagnose an underlying problem, such as in these pictures where a delayed sinogram shows a fistula. This got from our chairman. What about laparotomy for sepsis control? What's new there? Of course, another picture from our chairman here. Originally, the principles remain the same as they have done for a long time. Either exteriorize the bowel ends and resect the problem if it's an anastomotic leak or a fistula or an enterotomy, etc. Resect that segment of bowel, do not anastomose and proximally divert. That's sometimes done, but I think that's not appropriate in a septic patient. If this segment of bowel cannot be exteriorized, proximal diversion is another possibility to gain time and to improve the situation. If that's not possible, exteriorize the whole area as a laparostomy wound, which has been described quite widely now. If the abdomen can't be closed after these procedures, if we want to close the abdomen, there are certain ways to deal with that situation. Of course, a Bogota bag, bicural mesh to temporarily cover, which can be closed gradually in the midline, for example, to approximate the edges, sandwich pack, homemade vac, or a formal commercially available vac machine can be used as well. No real news there, except that the vac has been studied quite intensely over the last several years, the last decade or so. The good news with the vac is that, especially in American trauma literature, it works very well in closing an abdomen. Closure is achieved in most cases. The duration is pretty quick in the trauma literature. These two studies had mainly trauma patients. In septic patients, however, we need these vacs to stay on much longer, and this is part of the problem. Fistulation in these initial studies was quite low, so this is atmospheric fistulas being created just by injuring the bowel. The bad news is enteroatmospheric fistulas. So this is a study from Pete Sagar's group in Leeds, showing an uncontrolled study, showing a 20% fistulation rate in their patients having vacs, mainly after, I believe, abdominal sepsis. And this was borne out in the only randomized trial of vac versus bicural mesh, which has been done. And this is an American study in trauma showing very low closure rates in both groups, actually, but a similar fistulation rate. 21% of patients had fistulas in the vac group. So this is a problem. Experimental work supports that there's a problem with vacs, and this is why we still don't like them. This is 12 pigs in a Swedish study where we could see macroscopic changes following experimental application of a vac in the normal clinical way, and there were also profound microscopic changes in these pigs' bowels. For this reason, our chairman today and others in the audience participated in a large national audit over 18 months, studying all patients who had an open abdomen. And this was published in the Annals of Surgery a couple of years ago now. 69% of these patients had sepsis as the indication for an open abdomen. And interestingly, the issue of intestinal fistula did not come up here. The fistula rate was about 8% in the negative pressure wound therapy or VAC group versus 9.6% in the other group. So in this study, no effect was seen on the fistula rate. However, delayed primary closure was significantly worse in the VAC group versus the other group. So it's not as good as we may think in achieving delayed primary closure. So the last resort, and often a very good solution for these patients, especially after 2 or 3 laparotomies, is a laparostomy wound, where we simply leave the abdomen open and are able to directly drain the sepsis and any effluent from bowel and other viscera. So this results in better sepsis control than, most likely, than the other methods when it's indicated. It avoids abdominal compartment syndrome. The downsides are significant. It's very highly complex nursing care of these patients. The risk of secondary fistulas is even larger, and the reconstruction is complex because because the loss of domain here becomes quite large with time, and you probably need some form of reconstruction of this abdominal wall when it comes to restore the continuity of the GI tract. So to summarize this talk, where I try to highlight some new developments, is sepsis is still a major cause of mortality in our surgical practice. Easy cases treated just like before, CT, percutaneous drain. Remember to make sure people flush these drains. Consider doing a sinogram if it's a complex abscess or abscess which is difficult to drain perhaps. Do a sinogram before you pull that drain out. Complex cases, remember PET. PET can identify septic foci in patients where you suspect there might be such a focus. Severe cases may need laparotomy wounds for sepsis control. We are currently restrictive in our use of VAC. I personally don't use it anymore. Instead, more and more patients actually have a laparostomy wound nowadays. Thank you.